What do you think?
Remove waste products from the
Remove waste products. River, what else?
Say use the filter.
A filter to remove waste products?
Yeah, that's what I was gonna
Well,
go.
that's a new word anyways.
Right.
Mike, what do you got?
Secretes catecholamines.
It secretes
Does it
catecholamines.
secrete-
The adrenal medulla, the gland, is different from the kidney. It sits on top of the kidney.
Well, that's not right then.
It's weird because when you use the term, there's a adrenal cortex and adrenal medulla, and then down in the nephrology, when we're talking about just the kidneys, then we also have a cortex and a medulla there. Cass, do you have any extra?
Filters blood and produces urine.
That produces urine, good. Filter, and produces urine. What else? Certainly, if we pay attention to what we learned in class.
regulate hydrogen ions and bicarb and stuff like that.
All right, so acid-base balance, and then there's more. What else have we learned that the kidneys help do?
Sure.
Talked about it a couple of times.
Acid base.
Acid-base.
Blood pressure.
Would you like to repeat what other people say?
Yeah.
Just
I'm like processing the no from before.
So the other things that the kidneys do for us is helps us with blood pressure. All right. So we're always when we think of blood pressure to begin with, I would think that we would first think in blood pressure regulation. We think of baroreceptors, and then the baroreceptors sending a message through the hypothalamus to say, hey, our pressure is low, what are you going to do about it? But also in the kidneys, as the kidney itself is basically saying, how is our pressure? And it equates that to blood volume. And then, do you guys remember, like, how does the kidney then change our blood pressure? Two different ways.
It will not excrete fluid.
Yeah, it will keep salt. All right, so one way is when we're feeling like, hey, we're low, it will call for the secretion of aldosterone, again, off from the adrenal medulla, adrenal cortex, out of the gland. And then we will hold on to salt. If we hold on to salt, we'll hold on to water. And the other thing is the whole renin-angiotensin system. All right, so it'll release renin, turn to angiotensin, angiotensin 2, and then that's vasoconstriction. So kidneys and blood pressure go together pretty closely. Here's our macro look at what we're seeing. We have to know all these terms: the kidneys, the ureter, bladder, and urethra. And then probably more importantly, we need to know this structure more. You have two big old kidneys. A kidney's about the size of your fist, protected by our ribs, sits in the back, retroperitoneal. And what actually filters our blood is a nephron, and this is generally what they say a nephron looks like. And again, we're seeing a cortex area here and a medulla area. This isn't a gland; it is it's the kidney. And so here we have, I think, some sweet slides that will blow this up a little bit. We have that glomerulus. And so we have an artery under arterial pressure go into the kidney. As we go down into the microscopic or into the capillary kind of bed, we'll see a glomerulus. At that point, blood goes in there under pressure, and a bunch of what is in the blood is going to leave the blood and become filtrate. And the filtrate is then going to be in these tubes that are kind of a off brown, tan color. And so what doesn't go into filtrate? Jeffrey, that one's for you. What doesn't go into that filtrate? What stays in the blood?
Plasma.
Plasma moves. Plasma moves. I think when we talk about how much moves, it's 180 liters, not milliliters, 180 liters a day, which is a lot. 180 liters of fluid leave the blood vessel and go into become filtrate. So what else stays inside the blood vessel? Doesn't go into filtrate normally. Hemoglobin, which is a red blood cell, right? Alex, you have another one?
Too easy.
Go ahead, say it.
Oxygen?
Oxygen doesn't leave there. I don't think oxygen, we don't pee out oxygen. So the gases, I think, stay there. What else?
The white blood cells and
White blood cells and platelets, all those formed elements try to stay inside. Now, when we have a problem, then we start peeing out those things, all right? So sugar should stay inside the blood vessel. Sugar doesn't make a big jump until there's so much sugar that there's a gradient that the sugar is now going to be going into the filtrate, and then we pee out sugar. Protein also, so all the big proteins in our body, those don't go through there. And when we have big proteins come in here, they will gunk up this glomerulus. So if you have a bunch of myoglobin, because you're beating up your muscles, you will release myoglobin, that gets this gunked up because it's not used to having big protein molecules there. Then what happens is through this descending limb, and then this is the loop of Henle. What does its job there? Who punches in and works at the loop of Henle? What drug? What's that? Sydney, what drug is a loop drug? Lasix. Lasix and Bumex are both loop diuretics. What they're called loop diuretics because they do their business where the loop of Henle is, and this then is where sodium is reabsorbed. All right, where sodium is reabsorbed. You'll see, like even in this slide here, I have a whole bunch of things like this is where water goes back into the vessel. Kind of makes sense. Like right away, we're going to be doing water, and then here urea is getting sucked into here still. Sodium, potassium, and chloride are all going out here in this loop of Henle area. So I don't think you need to memorize any of those things, all right? I think you need to understand the concept, all right? The concept is throughout this area, there's special areas where you're going to be more about the movement of electrolytes versus maybe if you had any protons, amino acids, glucose, all of these things can go here. Does that make sense? Thusly, you can have pharmaceutically, they can make it so we can manipulate here, we can manipulate there, we can manipulate over here or over there. And so a loop diuretic is the one that we need to know. It works in this area here where it's mostly about electrolytes. Ultimately, you have an ascending, descending, convoluted tubules, and then this is the collection area, all right? So not much that you need to know. You just need to know the concept that much of our blood, or what we think of as our blood, leaves the system, plasma being one of the big things, leaves the blood. And then through just regular old osmosis and diffusion, the things come back and go back and forth from filtrate to back into the blood. I think we said enough about that. That, as far as A&P, is all you need to know, all right? So the big A&P questions are going to be, like, how does the kidney manage your blood pressure, all right? And that would be with maybe the use of aldosterone and the manipulation of electrolytes, which is going to manipulate water, and then the renin angiotensin system. I would expect quiz questions on that kind of hooyah. Otherwise, easy stuff like the kidneys are retroperitoneal, so injury causes bleeding in the retroperitoneal space. Not much. All right, we'll continue to talk a little bit more about it, about the A&P side as we go through here. So the UTI is the first thing, all right, a urinary tract infection. I was going to put in some extra slides and I forgot to. Luckily, I'm remembering. So UTI is the first thing to think about. Females more often than males. Usually develops in the lower urinary tract, like the urethra, and then it spreads if untreated. It doesn't mean all UTIs start that way. So if it is UTI in the urethra, it is also called urethritis, all right? And then if it's a bladder infection, and again, the number one way to get a bladder infection is for urethritis to get worse. Does that make sense? It's not the only way. It's just like the number one way. Usually, they start in the lower urinary tract and work their way up. What is it called when you have bladder infection? What's that?
Bladeritis.
Bladeritis? No, they went more difficult on that. It's cystitis. C-Y-S-T, I think, cystitis. And you don't really have to worry about, we talk more about cystitis when we get to gynecology, but you don't really have to worry about the difference between urethritis and cystitis, all right? As we go up, we have ureters, so it's ureteritis, probably, absolutely no question on that. And then as that condition goes all the way up to the kidneys, and as we go all the way up to the kidneys, it becomes one of those things like you could get a UTI that goes all the way up, and now you have a kidney infection. Definitely that's a way that it could happen, but also kidney infections happen from the other side. You're infectious in your system, and then you end up with a kidney infection. And anybody, what is the name for a kidney infection? That one is pyelonephritis, all right, pyelonephritis. So with pyelonephritis, it's all the same stuff that you would see with urethritis and then cystitis, but now you're gonna have pain, usually flank pain on one side or the other, and you can end up having like decreased urinary output and things of that sort. Here's all of those things then, and I'm gonna just switch these just a little bit. So with pretty much when you're thinking UTIs, think of painful urination, you have frequent urges to go to the bathroom. When you get there, you only pee a little bit, and you wish you would pee more. That can be painful when you're peeing. It gives you a visceral pain that makes you very uncomfortable. And the vital signs will be all over the place, all right? So for a UTI, it is one of the big things for us for septic patients in a nursing home. They're UTIs, all right? So as far as vital signs, it could be all the signs of shock. People die of UTIs. And that's usually going to be the septic side of the UTI. Most outside of the geriatric, most people don't call us for a UTI, all right? They hopefully call their doctor or just treat it themselves, and they don't have to involve EMS at all. But we get involved, all right? So what do you think our treatment is for a UTI? In one word. Supportive. Good. So ABCs, position of comfort, prepare for nausea and vomiting. So it might have something to do with Zofran, that's supportive. Patients with pyelonephritis or sepsis are going to be more of an aggressive treatment, all right? Again, by the time they have pyelonephritis, and pyelonephritis is going to be hard for us to diagnose if they haven't been diagnosed with it already. Again, a pyelonephritis,
Yeah.
There's your reading for it if you wanted to figure out how to spell it, but it is a kidney infection. A kidney infection. Again, you can get that kidney infection from it going from a UTI and getting worse, or it could come from the body and you're a septic and you end up with a pyelonephritis that way. So when it is from the UTI, the way that we would get it is he or she's been trying to treat themselves very, what would you say, unsuccessfully for UTI, all right? And then they've gotten worse worse and worse and worse over the last few days. Now they have, I think on that previous slide, it didn't show fever, right? Was fever on that slide? So, but if we're talking about a bacterial infection, which we often are, then we're talking about a fever, a mild fever with viral and higher fever with bacterial. When it is a UTI, that is, starts with a UTI, it'll be all of those things from the slide. The frequency of urination and the painful urination, and when they go, it stops before they want to pee, or when they want their urination to stop, it stops. When we're talking about pyelonephritis, starting at the pyelonephritis, that becomes less of the issue. But the kidney itself doesn't function, but it's usually only one kidney. So from there, it's really from an EMS perspective, it's hard for us to say, until they say, yes, I've been diagnosed with pyelonephritis, it's hard for us to say, oh, you got pyelonephritis, all right? We only get back pain and that's about it, all right? But if they had UTI symptoms for a few days to a week, and now they have back pain, that's where we start saying, oh, you probably have pyelonephritis now. You took too long to truly care for your UTI.
Does that affect blood pressure?
If they're septic, okay, it's septic shock.
So kind of present hypovolemic versus septic.
Why hypovolemic?
Well, the blood pressure goes low. If you went to the route of both kidneys are involved, is that gonna really throw off their blood pressure at that point then? Or will it kind of compensate through that?
It can go like the side send, vitals can go either way.
Anyway,
Yeah. So if you're, again, if you have pyelonephritis, it's usually one-sided, so one kidney's working fine. So they probably are producing urine and all of that. So you don't have all of the negative side of that would end up giving you a high blood pressure. So when you think of pyelonephritis, what you worry about is the septic side of that. Are they septic now? Because it's a close, easy for you to go from just an infection to a blood infection, sepsis. And so your aggressive treatment is basically for us starting IVs, right? And so if you look, we have protocols now. They want us to be more engaged in like figuring out if someone is septic, and they can present all over the place, right? Not all septic patients have fevers. Some of them are hypothermic. Most of the time, we're talking about pale, cool, clammy, all of the signs of shock. That could be your pyelonephritis patient. However, they usually are going to have back pain with that, one-sided flank pain. Any other ideas? What could we add for treatment? How else would you treat this patient with a UTI? I mentioned it was painful. All right, so we can then do what?
Pain management.
Pain management. And so pain management for these really are, and something we should concentrate on being a right answer is, we don't take people's pain away. We make pain endure, they can endure it, basically. They can manage it. They can tolerate it. So then there's kidney stones. And kidney stones are formed in your, that nephron that we mentioned before. Now here we form an excess of an insoluble salt or uric acid crystallizes in the urine. Calcium stones are the most common, and Struvite stones are more common in women. So insoluble salts, uric acid, calcium, and struvite. Could be any of those. Think of those, that uric acid one is a big one, and then cysteine. I doubt at the National Registry you have to say one or the other. You might have to know struvite is more common in women. When you have a kidney stone, it's released from the kidney, it'll go into the ureter, and as it's going down this ureter, it will stop. And then this will end up causing this whole kidney to be bigger when they take an x-ray, the whole kidney will be bigger because it's not letting out fluid, so it'll be like, it's called like hydronephrology or nephron. So a bunch of water just stays here and there's extra pressure in there. And then depending on who you are, you'll have different pain. So usually that is a back pain on one side or the other, depending on where the stone is and depending on how your nerves are, where you exactly that pain and how you'll describe that pain. This pain is another one where once this drops down into the bladder, that pain can start to go away. All right, so you'll have a decrease in pain. However, you still will have some pain in there because you usually have damaged the inside and there are nerves there that will tell you, hey, this still hurts, but it'll go from that bad pain to a less intense pain.
Hey, Steve.
Yep.
This might be a goofy question, but of all the different things that people can endure that can or can't cause pain, why is this something that causes like one of the most severe pains that somebody can have?
Yeah, I'm not sure. It is somatic. They have nerves that tell you more than the rest of like the visceral pain. It seems somatic in nature. I don't know. It's retroperitoneal. It's behind everything. I'm not sure why. And here's some of the things. Hydronephrosis is what the actual term is. Hydronephrosis. Obviously, that is your water's not leaving. Hydro is water. So here, hydroureter, it's an increased the size of the ureter because it's backing up water. This will actually be skinnier than normal, as it's but on the basically south side of where your stone stopped. Has anybody here had a kidney stone? And then how about patients with kidney stones? So they do seem to be in a lot of pain. All right, a lot of times they look like pale, cool, diuretic, like nausea, all of that kind of stuff because it's such intense pain.
Do you know if that is a pulsating or a rhythmic pain, or is it just intense and constant?
I've only heard it as tense and constant. So. And they don't, like for that, they can't find a position of comfort. So they can move around, so if it comes and goes at all, it's like when they move, they might have and this is visceral pain. They may have like, ooh, this is not so bad. Then they go back, oh, it hurts. And then when they can point to it, it becomes more of what I call a somatic pain. So it seems like there's nerves there that will tell them this is where it hurts.
We just had a patient transported, and it was exactly like this picture, like it hurts right here on the flanky area, but he described it as pulsating or rhythmic in nature, and so it's just interesting.
It might, that could be a peristaltic movement that moves stuff, so it would maybe it's spasming trying to push it through. So we can establish an IV and give analgesia, and again Zofran if they're all the way to feeling sick about this too. And so, any questions about kidney stones? And so, acute kidney injury is next. And then this one in your text, I think in the 8th, it calls it acute kidney injury. Some of you guys have the 9th edition. But a lot of times, acute kidney injury sounds like trauma. And we're not talking about trauma. Injury isn't trauma, all right? This used to be called acute kidney failure. Kidney failure is the same thing as AKI, acute kidney injury. So for some reason, there is a sudden decrease in filtration through the glomeruli. The causes, when you're not filtering your blood, is going to cause your toxins to accumulate. We're going to talk about these toxins a lot and call them nitrogenous waste, azotemia, urea. All of those are the waste products that are going to build up in your system. Ammonia is another one. So when those are accumulating in your blood and you're not perfusing through your kidney well, you're going to have harder times keeping up with acid-base problems too. 20% of critically ill patients develop AKI, all right? So we're going to talk about that, I think, in the next couple of slides. And the mortality rate is as high as 70%. All right. So just two terms here that I threw in. Oliguria is a urine output of less than 500 milliliters a day. Our normal is like 15 to 1800 milliliters. And then anuria is complete cessation. You're not peeing out at all. Oliguria is low, anuria is none. And so what do they look like? So generalized edema, acid buildup. We might see that in an increased respiratory rate, a feeling like they're short of breath, not able to catch their breath. High levels of nitrogenous and metabolic waste in the blood. So it might be that we get called to a nursing home or an urgent care center. Bun and creatinine levels is what they check. Bun and creatinine. Your bun and creatinine should be negligible, very, very small numbers. When those start to rise, that is directly related to kidney problems. And again, AKI isn't trauma. Don't think of it as trauma. The word injury, I think, confuses things. I don't know why they put injury in there. I like failure better. The reason that they don't like failure is it isn't failed. It's still working. It used to be also called chronic. There's acute kidney failure and chronic kidney failure. And so you'll end up with volume overload. You're not managing your electrolytes anymore. You're not peeing stuff out, so you're going to have volume overload. You tend towards hyperkalemia, uremia, azotemia, and so you need to know these words now too. Blood urea nitrogen is that bun. Blood urea nitrogen and creatinine. And so this is, I would say, to me, this sounds critical care paramedic stuff, all right? If you're getting bun and creatinine level questions on the National Registry, they're asking you hard questions. And this ends up being a metabolic acidosis. Acute kidney injury is metabolic acidosis. That's how we learned it earlier too. So we need to talk about the different causes of this. So we're going to talk about pre-renal, intrarenal, and post-renal causes. So what would be a cause of pre-renal acute kidney injury? Ethan, that one's for you. What causes your kidneys to have decreased glomerulus filtration before the kidney, pre-renal? Shock. Number one is shock. Has anybody got another one?
Diet.
Not really diet. I think if you went with severe dehydration, that could be it. And that would be under the shock side of it. Any other ideas? Critically think through it. What would make it so your glomerulus isn't filtrating anymore?
Diabetes.
And how would that do that?
Too much sugar and then hardening of the glomerulus.
Yeah, I think that would be good. So you have just damage to that glomerular artery. And then any others? It's a little bit, it's the obstruction, an emboli, all right? So some drugs will do it too, and it's usually then, when I think of the drugs, I think of it as overdoses, but it can be from repetitive use, and that goes to all the way to NSAIDs, all right? Just repeatedly over a long period of time using NSAIDs at high levels directly attributes to poor kidney function, and so that's a pre-renal way to get there. And so when you're talking about that pre-renal, the way or the signs that you'll see pre-renal acute kidney injury, the signs that you see is low blood pressure, and then you got things like signs of shock, right? Then when we get to intrarenal, what do you think causes intrarenal? Any ideas? It's happening now inside the kidney. It's inside the nephron where your problem is. And so those were tubules that we were showing before, where you had an ascending and a descending tubule and convoluted tubule. You can just have necrosis in that area. Medications that mess with the kidney can cause those things. Here, one that I think is a little bit different. It's kind of weird. I think rhabdomyolysis, to me, rhabdomyolysis should be on the pre-renal side, because it's myoglobin that dunks up your glomerulus. But here, in most of the places that you would look, I don't know if it's in your book at all, rhabdo is a inside the kidney thing, all right? It's intrarenal rhabdomyolysis. Toxins, and those are like, I know metals, when you have metal poisoning, those mess with your kidneys, all the heavy metals. And then trauma. Pyelonephritis is inside. If you have pyelonephritis, that's within the kidney. Within the kidney, you're not working well. That would also be one. And so here, this one, when we were talking about pre-renal, it was really shock. That's the number one way, in all the different ways that we get to shock, all right? So that could be cardiovascular or cardiac shock. It could be septic shock. It could be hypovolemic shock, all of them. And so, boom, this kind of makes sense. But now when we're intrarenal and we're talking about maybe trauma and medications or toxins, now we're going to have a problem with the kidney. So flank pain, oliguria, you won't be peeing, all of them should probably show oliguria and anuria. Here we can have hypertension, and then the headache, confusion, and seizure. So for me, I've only had a few patients that are like remarkable in my brain, like bad patients who ended up being like intubated and all kinds of stuff. And I could not figure out what was wrong with the patient. I have no idea what's wrong with you. You're just getting all of this stuff. It doesn't seem like this doesn't seem like drugs. It doesn't seem like alcohol. It doesn't seem like you're having a stroke. Everything is off, we've kind of got all of that stuff out. Sometimes these are critical enough to be intubated, not always. And then when we get to the hospital, we find that their kidneys failed, all right? And it was causing azotemia. And a lot of times, the first thing the doctor said or the nurse said, their ammonia levels were really high, which is one of those things that liver disease does the same thing, all right? So, but usually, if we're just talking about azotemia, nitrogenous waste, bun creatinine is another way to say that. These are how we're finding our patients, all right? We find our patients this way, and then the only way that we pick up on that they have a kidney problem is, how have you been peeing? Tell me about that, all right? So if they had a pre-renal problem or an intrarenal problem, again, if it was a pre-renal problem that caused the first thing, this acute tubular necrosis, that's sugar, that's hypotension. It's just that now they've corrected that, but we still have a problem intrarenal now. It's kind of why rhabdo gets into this part too. For post-renal is after the kidneys then. And so where are you going to have a problem? What do you think the number one cause for this would be? Number one in my brain anyways.
Kidney stone.
A kidney stone. It seems like the only one that we would have to know as paramedic students. I don't know if I've heard a UTI, but a UTI would be there too. So some problem with the bladder and urethra is probably, we throw cancer in there too. But now, if it's kidney stone and stuff, now we're looking at another sign or symptom. We have this hematuria. See this peripheral edema, that should have been in the other one too. You could have peripheral edema. If you remember from that last one, it said joint pain was in there too. Both of these can have joint pains as you're building up abundant creatinine and nitrogen levels. So peripheral edema makes sense for all of them, all right? The thing is that very often with a shock one, with the pre-renal stuff, in the short phase that we would have to worry about, they wouldn't have peripheral edema. So So again, post-renal, think kidney stones, maybe UTI, to where now your urethritis is not allowing you to pee. And that can cause you to have, especially if you're talking about small stones that are passing, that can give you hematuria. So what does hematuria look like to us most of the time? Lena, that one's for you.
You're asking what hematuria looks like?
Yeah, to us as paramedics most of the time.
Blood in the urine.
Who else has an idea? It usually looks like pee, all right? Most of the time, hematuria isn't, oh, look, I'm peeing blood, all right? Hematuria is, it's called occult, right? Occult? I think that's right. When you pee onto a microscope slide, they will see red blood cells. You're not supposed to see red blood cells. So most people don't pee blood, right? Bright red blood. All right. Most of the time, in my experience, again, again, you see these sometimes with Foley catheters, that is trauma where they've lacerated their bladder or cancer. All right. That's the only time that I've seen that. And I've had a lot of patients who have hematuria. All right. Hematuria is a lab test most of the time. Has anybody had a patient with blood in their thing? That happens, right? Do you remember what the diagnosis was for the patient?
No, I didn't follow up.
So most of the time it's cancer. It's usually not something little like this. Again, it's maybe yellow or orange pee, and that's a cloudy pee. What makes pee cloudy from our easy perspective? Multiple things, but it's white blood cells. So white blood cells, again, when you're having an inflammatory thing, which all of this can end up being giving you an inflammatory reaction to that area, boom, they're gonna cause vasodilation, same way as we call vasodilation everywhere. White blood cells will go there. And so instead of hematuria here, what you can have with post-renal is cloudy urine, all right? It's because they're getting a whole bunch of white blood cells that are going there, macrophage and such, monocytes, going to fight the fight and dying and getting peed out as white blood cells, as dead white blood cells, and it gives you cloudy urine. So here, I think I emailed this to everybody, right? Hope so. Here, these are 3 different YouTube things, and it covers all of the AKI stuff. All right, and a lot of it, like this one here, the Ninja one is an hour, it's probably an hour long. If you guys watch the Ninja Nerd guy, he does long things. These are both like 7 to 10 minute things, and it explains what I just said. If you want to relearn it maybe. So during your physical exam, evaluate the abdomen or other causes of discomfort. For the presence of ascites, how do we see ascites? How are we going to be able to figure out ascites on somebody?
Visually inspected.
What's that?
Isn't it like visually inspected?
Visually inspected. What else? What is ascites? Fluid in the abdomen. And it's extra. It's outside of their GI tract. It's just fluid in the abdomen. The way they can get out is just put in a big old tap and get the water out. How is that going to be something we recognize?
If there's a patient and they have somebody with them, like a wife or somebody who's with them every day, I mean, they usually go, oh my goodness, he looks like he's pregnant. I mean, they're just huge.
Yeah, you're going to have to ask the patient. Does this look normal to you? Or else it's one of the early complaints that they have.
No.
So it's, again, one of those things, like when we're doing an assessment, and again, when we're doing these scenarios, what we should be doing all of the time, when we put the patient into this, and maybe in your brain, this is when it triggers, when we're putting the patient in the ambulance, we have to say to ourselves, we need a differential diagnosis. I need the evaluator to see that I am making sure it's not other stuff, all right? I'll tell you, like, Andrew, how quickly did you figure out that this was a stroke today? Pretty quickly, right? I think everybody will know what's going on. within 4 or 5 minutes of starting your thing. You'll know cholecystitis, appendicitis, it's a cardiac chest pain, it's a AAA, it's a thoracic aneurysm, asthma, CHF. I'm also right now listing all the things that it could be. high blood sugar, low blood sugar, a seizure, GI bleed, what was that thing called, a renal calculi. Those are about all of the things that we are going to test you on for 20 minutes out of hospitals. The stroke, you'll figure it out right away. All right, everybody gets that. You'll figure it out. There is no trick to it. They're all, I think, pretty easy to figure out what's going on. For you to get the maximum points, you have to be able to figure that out. You should figure out what other stuff is going on. All right, there's almost always one other little thing that's not really a big thing at all. All right, if you don't get it, you can still pass. But if you don't get it, you can still pass. If you do get it, you're probably going to get a 3. All right, and then the other side of it is the instructor has to say that you expanded your patient assessment beyond what is obvious. All right, and that is a differential diagnosis. So it's very simply doing a head to toe, doing tacos, and saying to yourself, what is all the things that could cause abdomen pain? All right, and then basically say, it's not this, it's not this, it's not this, it's not this, it's not this. And you can say that to your patient. Doctors say that to their patient, all right? So this is what it looks like it is. It looks like it's a stroke. Let's make sure it's not this and this and this and this and this. Another way to try to make sure that you're getting points is by saying, like, on the way to the hospital, we're in the frame of mind that is differential diagnosis. We're trying to get points, and we said we already checked the temperature. We didn't earlier, right? But we checked the blood sugar today. Blood sugar was 100 and something. So we would say to the patient, well, remember, we think we're dealing with a stroke. This is what it looks like. Let's do another stroke screen and see how you do. All right, because we're supposed to at least do 2, and 3 is probably where you're supposed to be at. All right, and then we're going to say it's not your blood sugar is fine. It's not your oxygen level is fine. It's not your anything intra-abdomen, your abdomen is unremarkable. It's not your temperature, you don't seem to be having a fever. Does that make sense? Or you could even say, like, we're kind of ruling out that you have a bacterial infection, which a bad bacterial infection that's pushing you towards sepsis could give you stroke-like symptoms. So does that make sense? So that is where you want to, that is, if you're doing minimal things, that's the place that I worry about you guys failing. All right? I don't worry about you treating them correctly. The treatment's always easy on these, right? Albuterol here, magnesium sulfate, Mona, anaphylaxis is pretty easy, right? Sugar, all of the treatments are easy, aren't they? Like all of GI and GU is starting not even bring them to the hospital. Maybe treat with Zofran, maybe treat with pain. So the treatment isn't a big deal. Remember, therapeutic communication is there, so we have to talk nice to our patient and talk and be able to control our team. The first one is scene safety, and if we're saying something like, I would thoroughly assess the scene and take deliberate actions to provide for the safety of me and my friends, you've got a 3 there, probably at least a 2. And the last one is integration, figuring out what it is and treating it appropriately, and kind of understanding why you're doing what you're doing. The other thing that you worry about, that I would worry about for therapeutic communication is in a 20-minute out of hospital, it has to last 20 minutes. So some of that time, and they are all easy. I've never heard a student come back and say, I couldn't figure out what it was. They say pediatric asthma, CHF, cardiac chest pain, seizure, stroke, asthma, all kinds of, adult asthma, all kinds of things that they figured out what it was, and they all passed, hopefully do. But you figure it out, you're on your way to the hospital, you're gonna be there for 5 minutes and you have to just talk with your patient, all right? And some of that can be differential diagnosis. Again, for me, if I was doing a stroke patient, if I was at the National Registry and you did 1 stroke screening, I would fail you. And I'd say, I can give that as not a thorough assessment or not acting as a good EMT. Because to me, you have to do 2 stroke screens. If you're going to do 1, you have to do 2. All right. I'm close to being that way with 12 leads. So if you do 1, you do 2. All right. It should be that way all of the time. Does that make sense? Because we should be worried about, are they getting worse? For a stroke, us figuring out that they're getting worse has an impact on patient care. Getting better has an impact on patient care. So both of those things, you have to do repeated ones. So physical exam, flight tenderness, ECG, we're looking for the electrolyte problems, all the signs of infection, which is basically fever, and then we're going to monitor for shock. For management, we're going to look for all the life-threatening kind of stuff and treat those. It's going to be ABCs and IV boluses, but our IV boluses have to be very careful, all right? So some of our AKI patients will be producing urine, right? But if our AKI patient is not producing urine, then we want to be super careful with with how much fluid we're going to give them, right? So, and really manage their blood pressure one way, but maybe it isn't a bunch of fluid first. So maybe rule out dehydration, give them some fluids, and probably ask right away, start asking for more than like 200 milliliters of fluid. Say, this is what we got. I think it might be, a renal problem because reportedly they have not been peeing for 2 days. What do you want to do for their blood pressure if their blood pressure is now below 90? So you've already given 200 milliliters, which is a lot, all right? Then you might, what would we use to support their blood pressure? It's called dopamine. So dopamine helps with blood pressures, right? So you could use dopamine. When you were talking about all of these different toxins, some of them are going to weaken your heart. So the shock is a 3-pronged shock, all right? Maybe more 2-pronged, depends on how much they've been drinking. But it could be hypovolemia if part of this whole thing is they're not bringing in fluids. Your vessels can get big and your heart can be weakened by the toxins. So that's what you're dealing with. That's why fluids are there. But again, when you know that the patient's kidneys aren't working, fluids aren't a good idea. Does that make sense, everybody? When we know their kidneys aren't working, the fluids are not a good idea. We have to be super careful with them. The same thing is true about diuretics. When we know their kidneys aren't working, pre-hospital use of diuretics don't make sense. The idea of diuretics kind of makes sense, but it's kind of a doctor's and nurse's choice then. And you can give them a little bit of Lasix to see like, this is gonna work or not, all right? It could make things worse. Yeah, you guys wanna continue on or you've only been doing it for 50 minutes? Good, here we go. All right, so chronic kidney disease is next. So here we have inadequate kidney function caused by permanent loss of nephrons. So AKI is reversible. What we just talked about is reversible. That makes sense, right? It's just it could be as simply as they had a bad kidney stone. Remember, when we looked at that AKI, it was just talking about AKI. It said that when it was associated, again, AKI is very often just another thing. If you go back, if you in your mind's eye can picture that slide, it said a big percentage of people, 50% maybe, who are critically ill end up with AKI, right? So where does that happen? Well, remember when we're in shock, we cause vasoconstriction to a lot of places. We don't perfuse places as well as we perfuse our lungs, our brain, and our heart. One of those places that we don't perfuse is our kidney. When we don't perfuse our kidney becomes injured, AKI. So 50% of those critical people who die and had an AKI, and it said something about 70% of has a 70% mortality when you do get AKI. If that makes sense, those go together in your brain. here now, but again, it is, they had the problem, but then they can go live a long, happy life after that problem has been resolved. When we're talking about chronic kidney disease, we're talking about, slow descension towards being a dialysis patient, poor prognosis. So for some reason, and what do you think, to me, number one reason people go into chronic kidney disease? One word, two-word answer. It's almost always the history of a patient you're bringing to dialysis. Diabetic, yep, so diabetic, so it's that all of the time, blood sugar going up and blood sugar causing the vascular problem, which is, again, that was intrarenal, right? It's pre-renal, vascular. So that causes damage to your glomerulus when you have high blood sugar all of the time. Drug abuse is another one. So here, now on a constant basis, they're having problems with uremia and azotemia. Again, another way to say that same thing is their BUN and creatinine levels are going way up. Again, the N in BUN is nitrogen or nitrogenous wastes. So now we're looking at systematic complications, I should say system-wide complications. So very often they have altered mental status. And this is then when we're looking at it as paramedic students, we're thinking of probably patients who have been told they're going to start dialysis or they're on dialysis and they're skipping appointments. So when they skip an appointment or as they're moving towards this diagnosis of a chronic kidney disease, they have days where they're very tired, nauseous. That hypertension can go both ways, hypertension, hypotension. Since their kidneys are failing now, they're not getting rid of water, so that ends up being that pulmonary edema, peripheral edema, all of that kind of stuff. We don't really manage chronic kidney failure. We have to take care of them when they've missed their dialysis. The things that we should expect are like all kinds of different things then, right? Because diabetes is usually how they got there. It's a blood sugar problem. Since this stresses out their cardiovascular and their pulmonary system, we're talking about pulmonary edema, CHF looks, low blood pressures, all of the things that are associated with cardiogenic shock. Since it's an electrolyte thing, it can be a dysrhythmia thing. And so most of the time, we are just treating what we see. All right, we're treating what we see. That could be when we see peaked P waves, we're starting to think sodium bicarb and maybe calcium chloride. Otherwise, if they're short of breath, we would always be careful with water, giving them fluids, and with diuretics. But those are things that are still on the table. All right, we're still going to treat them. With those patients, you just want to call the hospital first and say, hey, this is the whole thing. Do you want me to do it, or do you guys want to do it there? We don't have diuretics here any longer. But it does totally make sense that you could give them diuretic. You should probably ask first. So here we are, more about the dialysis, and then here they get that end stage renal. So when I think of chronic kidney, then I think I'm already there at dialysis, all right? And so end stage renal dialysis, renal disease, that we're 100% into dialysis for a while. And so we have to think about, we get called to dialysis centers, and we get called to people who just had dialysis. When we're here, we're basically talking about both kidneys not functioning. After dialysis, the patient can have some weakness, a dehydration look to them. When they miss dialysis, we've seen this before. Like when we talk about missed dialysis, we talk about hyperkalemia, an acidosis. It's a metabolic acidosis. We've had that before in different scenarios and such. Signs of volume overload because they're not getting things straightened out. Shortness of breath, peripheral edema. That shortness of breath is probably going to be something that gave them pulmonary edema. When it gets to its worst, they've missed dialysis, that's maybe several days, or they're going from chronic to end stage and they haven't missed their dialysis, but they haven't basically made the change that they need to go to dialysis more. If you're familiar with dialysis, a lot of times patients start by only having to go maybe once a week, all right? And they have one kidney that's working at 50% or so. But then I think some of them go around 4 times a week, all right? I would guess there's some that have to go every day, all right? So I've only met, I think in my experiences, they're usually like Monday, Wednesday, Fridays, and then sometimes more than that. But Monday, Wednesday, Friday, there's probably Tuesday, Thursday, Saturday people out there too. So a uremic frost is if they're not getting things taken care of. And that is when you start to sweat out some of the salts. That's uremic, so urea is going to be part of that too. So if you lick it, I would think it's going to taste like pee. So don't lick it. Muscle twitching, again, that's electrolyte problems, coagulopathy, and chest pain. Coagulopathy, again, you need calcium for you to clot. In the late stages, confusion, seizures, and coma. And again, that's the buildup of toxins in their blood. So we're going to, of course, treat by going to a dialysis center. And pretty much, I think all of our big ERs, Corewell, Trinity, and U of M all have the ability to do dialysis. So it's ABCs and transport, pretty much. Just treat what you see. Here's a few different things just for, what would that be, terminology stuff. When you're talking to people who are now going to dialysis all the time, after a first few visits, they end up having to go to surgery and have either a fistula. What other medical term word could we use for this? You think? It's close to it anyways. A fistula is very much like, it's not exactly like though, anastomosis, all right? So here, most of the time when we talk about anastomosis, we talk about the extra blood vessels that we have in our heart, right? So we also have anastomosis in our mesentery, and when this is happening to your guts, your actual guts then, they call that anastomosis too. The small intestine. So one is they can pull these together, and that's where their needle is going to go. Another one, this is I think it'd be more apt. Is anybody really good with dialysis? Is you have a graft. So they loop a thing right in there and attach your artery to your vein, and that's where they're just basically going to put a needle right into that piece of tubing, basically that is comparable to the tubing that we start IVs on. So these patients especially then are going to be on anticoagulant therapy, all right? So this is going to cause some turbulence, so they're going to be on an antiplatelet aggregate and probably on something that's going to be like Xarelto or whatever, so they don't have clotting in this area. We are not supposed to start IVs there. We're supposed to avoid that harm if we're going to check the blood pressure, all right? So if you know somebody takes dialysis, you say, what side do you have a fistula or a graft? They say, yes, that's not where your blood pressure goes, all right? Blood pressure should go on the other side. So the complications from dialysis, you can have a low blood pressure, they can go into shock. And again, this is when they're at the dialysis center, you get called to dialysis centers because their blood pressure went down. Their potassium can go awry. Disequilibrium is usually going to happen afterwards, immediately afterwards, and they could have an air embolism while they're on the machine too. This guy here is just a picture off the internet, and he's doing an in-home, I don't know if he's doing it right now, but he's showing off his in-home peritoneal dialysis. All right, and peritoneal dialysis I don't think is nearly as popular as it was before. I think that's just a idea that what do you call it? The insurance companies are paying for blood dialysis or vascular dialysis, whatever that's called. Here, these what happens is they put in basically a tubing thing, and you dump your filtrate into your mesentery. So your blood vessels that are very good at absorbing stuff out of your small intestines, they're basically put into an environment where all your diacylate. So when we were talking about the kidney, all of that fluid that went from the vessel into the tubules, that was called filtrate, all right? So your doctor orders you your specific diacylate, all right? So your diacylate is this, and that has so much sodium, so much potassium, so much this, so much that. And when you just dump it into your stomach, into an environment where they're highly, what does he say, absorbable maybe, circulation, that is your mesentery that picks up nutrition out of your large or small intestine, that will also, through osmosis and diffusion, move things. And so you just dump it into your stomach, 1 liter, 2 liters into your stomach, boom, pull it out a couple hours later, and that's how you do your in-home peritoneal dialysis is what that's called. So most of the time we don't do that. We go to the place, hook you up to a machine, basically stabs you in there, your blood comes out, and your blood goes back in. Does that make sense? So blood comes out, goes into a machine, and in the machine is your diacylate, all right? Your blood is then put right next to, with cheesecloth in between it, all right? So your blood and your diacylate are there, and then potassium is going to go this way, sodium is going to go this way, calcium will go that way, magnesium this way, urea that way. Hopefully nitrogenous products will go the same way. If I said that way, both of those go out. And you sit there for 4 hours, and your blood slowly gets filtered outside of your body because your kidneys don't work. So does anybody know like who's doing that? Who's doing that for the patient? Any of you guys, any of you could do it. So it's like, you don't even have to go to college. So you get trained there. So RNs have oversight, and then dialysis tech, something like that, which is about phlebotomy training. So my students have worked at dialysis places before, all right? And all they did was hook people up to machines or watch people. They weren't even hooking them up, they were just watching them. And that's it. So to me, thinking that any of you guys could be watching these guys, things are gonna go wrong, right? So, not any of you guys, but it's not an RN sitting at their bedside the whole time. It's not a doctor right there. And what you're doing is taking their blood out of their body, putting it into an environment, and putting it back into their body. So to me, you have to say, wow, stuff could happen, all right? So the first one is disequilibrium syndrome. This one, 100%, is on the National Registry. And what happens is dialysis lowers the concentration of urea in the blood, all right? So it lowers the concentration of urea in the blood, which is a solid. And that, and your cerebrospinal fluid is going to continue to have a bunch of solids. So there's going to be an osmotic gradient that causes water to leave your vessel and go into your cerebrospinal fluid. And that is going to cause your ICP to go up. So this can be all kinds of different things. So this could be just a headache. Neck stiffness, all right? Or it could be what we can associate with ICP, Cushing syndrome, confusion, all of that kind of stuff. Generally, it all goes away. You just have to wait. And that's it. So we'll treat what we see, be supportive, start an IV maybe, but they don't need anything. They just need time for the gradient to go back the other way. I think we've seen all of these other, hypotension and shock, potassium imbalance, air embolism. We already talked about that. So for hypotension, what do you think we do? Pat, what do you think? If someone just left dialysis, they're at home now, they passed out twice, you check their blood pressure, it's 80 over 50.
Yes, included.
And how much?
50.
Good job. So it's not much fluid. They only need a little bit of fluid. So usually if we have somebody who's at home, passed out, blah, 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 we're gonna try to do like a tilt test, look for orthopedic orthostatic vital signs, and then give them 2 liters or so. These guys will very often, with just a little bit of fluid, get better. So if they're bleeding from the fistula, it's a bunch of direct pressure, all right, maybe up to a tourniquet. Hypokalemia, we're going to treat just as normal. If they may present with bradycardia, and we'll treat it like bradycardia. Hyperkalemia is all about sodium bicarb and calcium. And so for this, how do we, if we took care of somebody who has peaked T waves, with peaked T waves and weakness, confusion, how do we treat that patient? Emma, that one's for you. Peaked T waves, confusion. We'll give them some hypotension, a weakness.
Fluids.
And so fluids,
Supportive care.
supportive. What else could we do?
Ask for chest pain.
No chest pain.
Fluids. I said that.
What ends up being the trigger for us to give sodium bicarb? What would I have to write up there for you to say? Sodium bicarb. What's that?
Dialysis or something like that,
It is. They missed dialysis. Well, they have peaked T waves, so either they missed it, or it could be at a point where they go twice a week, and it's time for them to start going 3 times a week. What I have to do to tell you what would be the trigger?
Hyperkalemia.
Hyperkalemia?
Yeah, with T waves, do sodium bicarb.
All right, so were you thinking that Emma should have said give sodium bicarb? Yes?
Yeah.
All right, and so how do I give that sodium bicarb?
IV,
Good, how? Tell me more.
1 milli equivalent per kilogram.
Good, that's the good national registry answer is it's 1 milliequivalent per kilogram. You don't have that. Generally speaking, you probably have 50 milliequivalents, right? You probably have 1 yellow box, I think it is. Does anybody know, do you have 2 yellow boxes, which gives you 100 milliequivalents? So since we don't give it very much, we used to have two big yellow boxes next to our 2 big blue boxes, which is dextrose. But since we hardly ever give it, I figured that we probably only have 1 box by now. If we're just talking about this patient who is alive, we should take that, whatever amount that we have, which is probably 50 milliequivalents, and put that into probably a 500 bag or 1,000 bag. And are you guys familiar with the term piggyback? That in? So we piggyback that in. That means our main line would stay normal, and we would attach a needle into the line or use something called an extension tubing with a stopcock, all right? And then we can drip that one in again at like the 10 or 20 minutes, all right? There isn't, we don't fix acidosis fast, all right? It's the same kind of thing. We don't fix sugar, hyperglycemia. You don't want to fix that fast. You want to fix it slowly. You don't want to fix acidosis fast. You want to fix it slowly, all right? So when we do that, that's just, and when we're doing that, that's really kind of a shotgun approach to hyperkalemia. You're not going to make a huge impact. You shouldn't like start it and go, let's do another 12 lead because I'm sure the T waves are now perfectly normal. It's going to be a slowly over hours. We want them to go back to normal. All right. So I would think calcium is not going to be the answer. All right. Calcium, giving the patients calcium is usually not going to be the answer. All right. But it's there. Right. Now, for us to pull the trigger on peaked T waves, I should say on sodium bicarb, it was peaked T waves with some symptoms. It can't be just peaked T waves, right? If they don't have any symptoms, I'm probably not going to treat it at all. But now it's these things with those, with a good history that says, yeah, I think that this makes sense. I wouldn't do it, and we don't have a protocol that just says do it. I would call and ask and say, this is what I think we should do. So then, what would make us pull the trigger on calcium? Any ideas? Calcium is a little bit different because it isn't well, like if you just read about calcium chloride, it'll say, like early on, it's not good for VTAC. All right, you don't give it to VTAC and VFib. So if you just come across VTAC and VFib, we shouldn't think, let's not do amiodarone. I heard calcium's awesome, let's just give calcium, all right? They've actually done some fairly recent, like in the last 10, 15 years, research, and they say you don't do that. Don't give calcium for those. However, we need a trigger, like when do we? Calcium chloride is an antidysrhythmic. All right, I think it's very often listed as like the fifth area of the von Williams thing, the von Williams class 5. It is with it's first of all, if you remember, it's not just peaks T waves. Now we're going to get wide QRS. We're going to probably get extended PR intervals. All right, so and then in your thing, I don't know if I'm spelling it right, but it's a sine wave, all right? When they're talking about a sine wave, it is just that it no longer looks as much like a QRS. It's like a sine wave is actually something that is electrophysiology. Is a sine wave goes like this, all right? So when does that sound right? So your QRS is just widening out and rounding off up on the top. By that time, less as an antidysrhythmic, more as we need to change some electrolytes, all right? You're trying to put calcium where it is because potassium is so screwed up that really screwing up calcium too will get them screwed up on both sides of the fence, and that may normalize things. Does that make sense? You're then giving calcium chloride as an electrolyte to try to make it so we have less of a electrolyte imbalance. Calcium chloride, calcium gluconate would also, you're giving it for the calcium. So here, when I think of calcium, now, I don't think of it for VTAC and I don't think about it for VFib, but I do think of it for obvious hyperkalemia and PVCs. Maybe runs of VTAC. All the different ways that we describe PVCs, like multifocal, happy-no-la, bigeminal, all of those couplets. Because when if you're hyperkalemic, we're not supposed to use amiodarone, right? So when potassium is a problem, we don't use amiodarone. Hypokalemia, hyperkalemia, we'd want to stay away from the potassium channel blocker. Kind of makes sense, right? So then we have lidocaine, procainamide, and calcium chloride. And calcium chloride, when do we hear about using calcium chloride? You guys know, like most of the time, like when calcium chloride is going to be like what you're giving, the other one is in Crush syndrome. So it's part of the treating patients in Crush syndrome. And why is that? It's because Crush syndrome gives you hyperkalemia. All right, so when do you pull the trigger on it? It isn't like right away, like, oh, let's just give a bunch of calcium chloride. It is after you're starting to see cardiac signs that they need some electrolytes. What would that be? The peaks T waves. Well, you're already doing something about that with sodium bicarb. The sodium bicarb isn't like, boom, we give it, didn't work, because we'd be giving that over a long period of time. The time that would make you think that you need to pull a trigger on calcium chloride is when you think the ventricles are irritated, to get a little bit of calcium chloride. That's all I can think of. I would think calcium chloride, when you're taking the National Registry, be cautious of calcium chloride. So you should say to yourself, what else makes sense? What else makes sense? All right, because the trigger is late in the show. Does that make sense? It's late. Before that, you're going to give sodium bicarb. You're going to try and fix hyperkalemia and the other ways that we fix hyperkalemia. Does anybody know, like, what other way do we fix hyperkalemia? There's two other drugs that, one of them is kind of in our drug box. One of them definitely is in our drug box. The other one, we have to give this to give the other, which isn't in our drug box. Any ideas? It's not Lasix. So one is albuterol. All right, giving albuterol. Albuterol pushes, for some reason, potassium back into the cell. All right, albuterol pushes potassium back into the cell. Usually, if somebody is hyperkalemic, the reason they're hyperkalemic is the cells have gotten rid of the potassium. So what we want to do is put the potassium back in the cell. Our blood has a narrow range that it can tolerate having potassium at, 3.5 to 5, all right? The other drugs that are thought of for crush syndrome is you give the person dextrose and then a bunch of insulin, all right? And that opens up the cell also, all right? So insulin is actually what you want to give. Insulin opens up the cell, it opens it up in a way that potassium can go back in, all right? So, but we don't want their blood sugar to go, so you usually pre-medicate them with a little bit of dextrose and then give them insulin and potassium goes back in the cell. Disequilibrium syndrome, supportive. Air embolism, we put them in the swimmer's position. What do you think the swimmer's position is? Anybody know that one? It's called the swimmer's position because it's a dive medicine kind of thing. So when somebody's having an air embolism from that, the very basic treatment is left lateral recumbent and in the head down position. So and so you're like this. So and the thought is, does anybody know why would they say left lateral recumbent? The body would be kind of straight though. Like when I think of left lateral recumbent, I think it's all like jacked over like this and this, like the rescue position. And then head down position.
So it doesn't move, it's especially go to your head?
The air doesn't go to your head. It just seems made up to me. I was like going, did they research this? They just made it up. They say that the air bubble will get caught in the right atrium. If you're in the left lateral recumbent, air will go, it will just sit in your heart and not go to your head. I don't know. I'd like to see the research on that. Go ahead.
If you're responding to cardiac arrest, the patient is like a known dialysis patient, would you avoid giving them amiodarone even if they were in BTEC or BFIB?
I don't know. They're dead already.
Yeah.
And they missed dialysis or something like that. I would rather give lidocaine. I don't know if I'd jump on calcium chloride yet, but lidocaine is where I would want to go. And then if they're at a dialysis center and they're on the machine, this is just an expectation kind of fun fact stuff. Clamp the tubes and take the patient off the machine. All right. So the same thing as if you're thinking air embolism and they're still on the machine, we should be clamping tubes, turn it off, get them away. But we don't have to do that, right? We'll be at a dialysis center. Hopefully, not everybody there just died of a zombie apocalypse or something. So we'll probably let them do that. For heart failure, it is everything that we do for heart failure. all right? It is pretty much the same stuff. If they're producing urine, all right? So this is the one thing that you have to assess or get a history from. Are they producing urine? Is that still part of their life? They do that. When they are, then you can still use diuretics there. And in heart failure, we're basically, I think, going with left-sided heart failure, pulmonary edema. A heart attack, everything is the same. You can give nitro, aspirin, morphine, everything. Hypertension is supportive. Pericardial tamponade, treat that. And uremic pericarditis, it's all, you treat it as you see it. You're treating what you see. And now the worst part of the slide presentation. So the first thing here is male genitalia tract conditions. So for this book, we get like a couple of pages and the girls get a whole chapter. But epididymitis is usually bacterial, whereas orchitis is this one is usually viral. So you have to know that compare and contrast kind of thing, like croup and epiglottitis. Infection that causes inflammation of the epididymis along with the posterior border of the testes. So here is the thing. I don't think this is in your book. It's positive Pren sign, P-R-E-H-N. If you lift up on the testicle, the pain goes down. It's going to be different for a testicular torsion. Orchitis, one of the testes are infected. Pre-hospital management is supportive, bring them to the hospital. This Fournier, probably French, right? Fournier, gangrene. This one, go ahead, Google images on this one. Can't unsee some of that stuff. But it causes a gray necrosis. I think I got, nope, I don't have a little thing. That causes like probably nothing for us to memorize for that. I've never heard of that being on the National Registry. Could have started with trauma, doesn't have to. It ends up being like it's gangrene, all right? So they end up with a gray to black, swollen, and then things just start to slough off. Testicular torsion is the worst one for us as far as our differential diagnosis. This is what we should lean towards, just like for female childbearing years, when they have abdomen pain, we say it's probably ectopic pregnancy, all right? So that's what they want EMTs to think that way. Here, when somebody's complaining of ball pain, you're basically saying it's possibly testicular torsion. And now we have like a 6-hour window where he has to have this either surgically or externally manipulated to where he has blood flow again, or he loses a ball, all right? So you have reduced blood flow. So this is a mesenteric pain. It's the same, I should say, a visceral pain? No, ischemic pain. It's an ischemic pain. So your mesentery can have a mesenteric ischemia, your brain can have ischemia, your heart can have ischemia. Here is going to be ischemia of your testes. Mostly it's puberty and young adult. Very often they talk about it being after some sort of physical activity where they were jumping around and such. It absolutely doesn't have to be. It could happen after trauma, so kickboxing and all of that kind of stuff. Gives you what we're used to, like getting kicked in the nuts kind of stuff. So pain, a lot of belly pain, all the way to nausea and vomiting. Usually it will hurt on one side more than the other. That could have also some edema. And then this is negative Pren sign. So when you lift up the testicle, it still hurts. All right, it still hurts, a negative Pren sign. And so you transport promptly